Okay, we're live now with the One Thing podcast, and we're going to be speaking about Ehlers Danlos syndrome. I'm here with my guests, Dr. Jessica Pizano and Sabrina Vaz.
Yes.
Did I pronounce that correctly?
Yes, you did, Adam. Thank you.
Okay, thank you. Well, welcome to this episode. I'm really excited to speak with you about EDS, and it's something I've been wanting to do for a long time. A lot of people have reached out to me in my practice wanting to learn more and understand this condition. So I thought we could jump right into understanding how you got involved with working with EDS, and maybe we can start with Dr. Pizano. If you could just share.
Sure. So in my practice, Mast Cell Advanced Diagnostics, we work with a huge number of EDS patients because we see that there is a connection between EDS, mast cell disorders, and dysautonomias. So we work with all of those kinds of rare diseases or zebra diseases, as we like to say. As a doctor of clinical nutrition, my role is really helping to unravel all of the food intolerances, what's driving the various issues a patient has, and really working on what I like to call medical advocacy, which really is a fancy term for I understand all the science that goes into finding these rare diagnoses, and while I can't diagnose as a doctor of clinical nutrition, I work with all the top specialists, and so I tend to be the one doing all of the digging and background and advanced labs and understanding what they mean, and then advise the physicians in terms of how that patient should be diagnosed. We have a comprehensive practice here. We work with my sort of clinical nutrition level. I then have some master's level nutritionists that help with execution. I have somebody that does neural retraining work, and then I have Sabrina Vaz, who is our Pilates expert, who is so important with working with our EDS patients. So I'll let her talk a little bit about what she does.
Thank you, Jessica. So basically what I do is I have various certifications in the fitness and exercise industry, but most particularly I work with Pilates as a form of corrective exercise for people with EDS, because Pilates truly is an exercise system that can really help stabilize all the really small muscles in the body. And it also is an amazing way of helping people with EDS learn how to stabilize through their pelvis, creating a strong foundation kind of for their spinal column, so that then they can take that to other parts of their body and, just start learning how to move really with a lot of strength and stability so they're not dislocating as often.
Okay, well, thank you. I think that's a good place for us to start in our conversation. And you mentioned a number of things that people with EDS deal with. For people who are not aware of EDS, I sort of put in our show intro, that it's at its heart, it's a connective tissue disorder that has certain features. Maybe if you could take us through some of the features and general definitions of what people with EDS deal with.
Sure. So the first thing that we should really mention is that Ehlers Danlos is a general category and there are subtypes. Most people have what we call hypermobility Ehlers Danlos syndrome. That's the most common kind, but there are assorted other types like classical type, which we probably won't be just talking about too much today. That's really when people can really kind of pull their skin way beyond the normal limits. I'm talking inches away from the body. There's vascular type, which can cause early death and major problems with blood vessels. People usually die of an aneurysm by their 30s, unfortunately. But hypermobile Ehlers Danlos syndrome is actually quite common. There is no genetic marker that we look for with hypermobile Ehlers Danlos syndrome as opposed to other types of genetic connective tissue diseases. There's still some genetic findings I tend to see when I look at genomes in this population, and I've looked at thousands of them. So I have a lot of clinical experience. And what we typically see is, whereas We might need a homozygous, meaning both mom and dad give an affected allele to the child to have a particular genetic disorder. With hypermobile EDS, we might only have heterozygosity, so only one allele is affected, or with homozygous non-pathogenic variants that cause it. And really what we're talking about is the connective tissue isn't going to be programmed properly from a genetic perspective, which can cause all sorts of subluxations, dislocations, just generalized weak connective tissue. But we do see sort of hypermobility through certain joints. We do what's called a Beighton scale as a means of assessing. This is looking for various kinds of things like, do your knees hyperextend, meaning do they go beyond straight? Do your elbows go beyond straight? If you stand with your feet together, can you bend down and put your hands flat on the floor? If you were to take your hand up straight against a wall and sort of pull back, does it go to 90 degrees or more? You can see mine does. I do actually have hypermobile EDS. And then finally, there's what's called thumb sign, which is basically, can you take your thumb all the way up like mine does, like that? And if you can do four or more of those, there's a very good chance that you have this. But we can also see other issues. Heart valve issues are really, really common, whether we're just talking about slight regurgitation issues or, defects that actually require a replacement of a valve. All of these things can happen either very early on or as people age. So there's those sorts of aspects, but you also have, as I mentioned, the connectivity with dysautonomias, and that's specifically because our blood vessels are connective tissue. And in every blood vessel, we have what's called a baroreceptor that helps to control blood flow and blood pressure. And that is a nervous system component. And so connective tissue being weak sets off that baroreceptor, and that's how we end up with changes to heart rate and blood pressure, typically low blood pressure upon standing, and then a marked increase in heart rate at like 20 beats or more per minute above what's typically found in a seated position. For the same reason, we see lots of mast cells in that connective tissue, and they like to go haywire and cause all sorts of non-allergy but allergic type reactions that we find in our mast cell patients.
Okay. And so does someone have to go to a specialist to get diagnosed with EDS, or can a primary care doctor technically diagnose this? Because a lot of my patients seem to want to speak with a geneticist to kind of go through some formal diagnosis.
So while, technically a GP could make a diagnosis, most are not particularly well informed and feel it's quite outside scope of practice. So usually you're looking at somebody who is a geneticist, or perhaps some rheumatologist will work with it. And then you have some of these doctors that work specifically with the population. Sometimes they're, physiatrists, pain management specialists, orthopedic kinds of doctors, allergists, immunologists because of the tie to mast cell disorders, and certain types of cardiologists dealing with dysautonomias will be familiar and might assess. Ultimately, many will get referred to genetics because one of the diagnostic criteria is ruling out other genetic connective tissue diseases. And so they do typically want to run a connective tissue disease genetic panel and make sure that the clinical diagnosis is in fact what holds true and we don't have a pathogenic variant to another connective tissue disease.
I see. That makes sense. And Sabrina, maybe you could comment on this. There seems to be this onset of the diagnosis kind of falling in line with athletes or dancers or performers, that based on some of their ability to be hypermobile or maybe athletic in ways, they'll kind of choose certain paths, and then that might lead them to eventually finding out that this hypermobility is potentially causing problems. Can you speak to just like the population that you tend to see, that kind of their background and kind of comment on sort of the athletic background?
Yes, absolutely. Definitely, without question. I think people who have Ehlers Danlos before they're diagnosed do tend to gravitate toward maybe ballet or even yoga or other types of sports where hypermobility is looked upon as, a really great feature. Joe Pilates himself used to work with a lot of contortionists. And most likely, he died in 1967, so they were not being diagnosed with Ehlers Danlos, but most likely a lot of those hypermobile bodies that he worked with were also would have been diagnosed with EDS. So without question, especially in the ballet world, which I was a dancer, so I can understand that, you're constantly working on increasing flexibility. So if you have an easier time with that, the ballet world will really favor you. If you're taking a dance class and, you're the person that's able to get your leg up the highest, then you're the person who's going to make it to the front of the room. So it's encouraged. And I've seen a lot of dancers who end up really, in a lot of pain, and they just don't understand why until they're actually diagnosed.
Yeah, and that's what I was going to say. Is it's like the hidden world of like when they go home at the end of the day of, after the dance studio or after the performance. It's like, can you share what it's like typical to deal with? Because I think people can conceptualize sort of pain or aches and pains from exercising and what have you, but I think what people don't realize is with the Ehlers Danlos population is how different the pain is that you deal with and how difficult it is to kind of find pain relief.
Well, it's not just even just the pain, but sometimes you might have a dancer who, there's various parts of their body that will constantly dislocate. I have a person I work with, she's always dislocating her rib, and it was happening throughout. Like she would come home from dance class and her right rib would be out, and she actually learned how to try to put it back, which is just a horrible thing to have to deal with on a regular basis. Other people just the pain is so severe that they feel like they can't even get out of bed. There's other parts of their body that they might, dislocate, shoulder, different populations. The other thing that I find with a lot of people that I work with Ehlers Danlos is that they either pronate or supinate their feet. And a lot of times, ballet dancers in particular, and I refer to ballet dancers a lot because, as I said, I was a ballet dancer. I'm certified by the Bolshoi Ballet. And in Russia, they take the children, with higher companies like the Bolshoi and the Kirov. These young kids can't just go in; they have to audition, and so a lot of them have no dance experience at like 9 or 10 years old when they're auditioning. They have no dance experience; they're only judging them on their flexibility. So a lot of times, a lot of these kids actually have hypermobile bodies and EDS, and they're in a lot of pain, and they're being forced to stretch out even more. And that is another reality. A lot of times people with EDS think that, oh, if I just stretch, like this is hurting me so bad, if I just stretch a little bit more, and it feels great at first, but then it actually creates more pain.
Mm-hmm. Yeah. I think there's, when you don't have hypermobility, there's sort of some feedback as far as how far you can take a joint, right? And you can kind of gauge when you're reaching to that point of potential injury or trauma to that stretch or that tension. And in EDS, is the feedback different?
So yes, without question, the feedback is different. They don't feel it. So what I was actually saying is a lot of times people with EDS will pronate or supinate their feet, and so that's something that we try to work on. But in the dance world, a lot of times they'll pronate, so we say rolling in, but it's because they're so open through their hips. So it's a look that ballet world really likes. So it's encouraged and forced even more. And then because of that opening of the hips and that forced turnouts, it causes a lot of dislocation in the knee, a lot of dislocation in the ankle, and they're just not understanding why they're constantly rolling over their ankle, or why their knee is always giving them problems. And so going back to what you were saying, yes, so the stretch actually is, so they go beyond what Jessica said. It's beyond that straight line. A lot of times, like if you look at a principal dancer, you'll see this beautiful leg line, but it's like the leg is no longer straight. There's like this bow to the leg that's hyperextended, and might not even be feeling that at first, until until it starts to really catch up with her. So yeah, there is that no point of where they're just constantly wanting to stretch, and that stretch causes severe pain.
And I think if we kind of take that out of the dance world and look at some of our general population that deals with this, because at least with a dancer, there's a lot of conditioning that's going along, a lot of strengthening as well as the flexibility. So they tend to hold it together to a certain level beyond what we see in our non-dancing population that has this condition, where the joints are so hypermobile. And they don't have enough muscular control to hold that joint, that they lose what's called their proprioception, which is really how we sense our body in space and time. And so we have all these balance challenges that arise, a lot of falls. A lot of times they're just moving their body, and that's enough to sublux or dislocate, which is going to cause exponentially more pain than somebody who has the muscle control to control the joint, which is why I actually have, Sabrina as part of our team, because it's so important to get them functioning and moving, even though in their minds, a lot of times they're very scared to move and they don't want to do any kind of form of exercise because they think of it associated with getting injured. And even physical therapy, unfortunately, rarely works just because of the way the model is set up, where we typically are addressing an injury that's occurred versus looking at the entire kinetic chain. But there are things you can do. There are compression garments that can be really helpful. There's working with all the small muscles that Sabrina's doing with patients. There's all sorts of neurological inputs that we can use, proprioceptive kinds of insoles and things that are out there. And so it's really about exploring those options, because in terms of pain relief, which is really where we started, we don't want to medicate this very much, because then you're looking at a lifetime of needing more and more medication to control pain levels, which typically will go up if you're not doing anything about them rather than down. And so it becomes really important that we work on stabilizing the body and getting rid of pain from the sense of having increased function, so that we're not having that pain associated with dysfunction.
Yeah, and I'll love to circle back and hear more about the Pilates and some of the therapies that you're doing. I want to touch upon something that I think Jessica, you and I have discussed, is the digestive aspect, and a little bit about mast cells. And it seems to be that there's a strong link between Ehlers Danlos syndrome and dysbiosis, or SIBO or IBS. Can you speak to that if you see that in your practice?
Sure. I'm not sure that I would say SIBO specifically. Usually we're going to have SIBO-like symptoms because of histamine intolerance. And some of that is because of the amount of mast cells, I said, in the connective tissue directly. So the faulty connective tissue trips off the mast cell. Mast cells then degranulate, losing things like histamine and tryptase and other mediators. That causes inflammation. Histamine is a known cause of leaky gut or intestinal permeability, whatever we want to call it. And so we end up with all these kinds of problems. Because of that, we can have opportunistic infections. And we often see that in our EDS patients, we can have acquired, or so meaning they happen because of an infection, or genetic immunodeficiency syndromes. And that tends to really cause all of these chronic infections to worsen and not be able to be dealt with by the immune system or by a typical course of treatment from a physician. And so they do become this sort of lifetime kind of issue. You mentioned SIBO. Usually that sort of bloating kind of symptom after everything you eat has a lot to do with histamine intolerance rather than true SIBO. Occasionally we do find that, but I don't think any more frequently than in any other population. And so histamine intolerance is typically a result of decreased function of the enzyme diamine oxidase, or DAO. So a riboflavin-driven reaction. So oftentimes we find low riboflavin status in these patients, and that's something that we can actually work on. You also have a connection with connective tissue, because connective tissue requires a lot of vitamin C in order to be created, and vitamin C is a cofactor for for another enzyme, alcohol dehydrogenase, that breaks down histamine. And so that can also contribute to the histamine intolerance we find. Many people with EDS have just histamine intolerance, but if you have that predisposition where the wrong epigenetic influence, it could easily put them over the edge into a mast cell activation syndrome status. And so it's something that even if we don't have it in one of our patients where we do know there's EDS, we're always making sure that we're not seeing early signs of that disease.
Okay, great. And so there's also a strong kind of mental health aspect of dealing with EDS, just like I'd say most chronic pain conditions. Or is there unique approaches that you found that you take in kind of, I know that you integrate a lot of healthcare providers in what you do. Can you speak to the mental health aspect?
Sure. So there are two sides to the mental health picture. One is the sort of difficulty people have at coping with either a new diagnosis or a chronic illness that's been, challenging them for a long time. And then there is the neurotransmitter derailment we see with a histamine issue, because histamine tends to increase all of our excitatory neurotransmitters, things like norepinephrine, epinephrine, and glutamate, while decreasing inhibitory neurotransmitters, things like serotonin and GABA and glycine. So we can have true, actual neurotransmitter issues. That's something that I actually work on in the practice in terms of fixing the biochemistry for them. But you also, as I said, have this sort of fear issue, people who haven't tolerated or scared to introduce a new supplement, medication, or food that could be really helpful. And that's where we use neural retraining in our practice. I have someone on my staff, Jamie Blazinski, that does an amazing job with them in terms of kind of giving exercises to overcome some of these belief systems so that they can make progress. And then I have to say, one of the biggest things that we use for mental health is Sabrina's work. And for many of our patients, they're not willing to do the neural retraining. They feel like they have it together, even though that they have this fear system in place, or, kind of feel like they're kind of stuck in a pattern, but they are willing to do something about their joint pain and understand that exercise is really important for their health. And the thing about Pilates is that they can see progression relatively quickly if they're doing the work. And so that is going to be huge mental health wise, just right there, let alone, anytime you look at studies on exercise and mental health, we always see positive impacts.
Yeah. It's that's a really good place for us to launch into hearing more about the Pilates as well. So if you're sitting down with a patient for the first time, Sabrina, can you give us some highlights of some of the education you do? Just, as far as what are some of the initial things that you share with them as far as concepts?
Absolutely. Of course, every body is different, even an EDS body. One of the first things I start with is basically how they're standing and the placement of their feet. So just kind of teaching them how that they can stand in a stable manner without allowing their weight to shift or without pronating or supinating, and just kind of connecting and lifting the pelvic floor up as they stand is really an amazing concept for them, because they're used to really kind of shifting or having a forward bend, and so a lot of people with EDS tend to tilt their pelvis underneath them. So there's all these various different postural issues that they have going on. So when we just try to start changing that from the feet upward, it makes a huge difference. So that is something that I usually start with. And even if it's somebody who might have proprioception or balance issues, I can actually talk about how they stand while they're staying seated. So basically anybody can do the work. So then we take it up to the pelvis and we talk about, whether they're rocking forward or rocking back or shifting, and just teaching them how to sit upright on their sits bones is another amazing concept, because it starts to activate their abs, and it just makes them feel so much stronger and more stable. And it's homework basically that they can do when they're not in session with me. So it has a large impact. As Jessica said, it's great for mental health as well, because they're feeling they're a success. They're making a difference in their body, and that's really powerful for anybody. And then the other aspect of it is there's mindful breathing involved, and anytime that you get breath flowing through the body, it's really beneficial for that as well, for mental health.
That's great. Yeah, I think what I'm hearing is there's a high degree of awareness that's probably developed through working with someone like yourself, which and technical things that if you're kind of going to a physical therapist that may be working on more movements that are kind of larger movements that might not register, but you need more of the granular stuff of the kind of fine-tuned details of like how to adjust your pelvis and how to stand, how to sit.
Exactly.
I can see how that
connection between the movements, because typically you go to physical therapy because you've hurt your left knee, and that's what they're going to work on. And maybe if you have a really good one, they'll work on the left hip or the left ankle, depending on where they think the problem is coming from, which is not by any means a dig at the physical therapist. Most of them know that they're not doing as much as they could for the patient, but that's what the insurance company will pay for the individual. So it becomes one of those things where the insurance model doesn't help somebody with a connective tissue disease like EDS. It just puts them in this world where they start to see some improvement, but then just as they're actually making enough gains to actually be somewhat functional, they're dismissed from PT, and now they start to, regress or have additional issues, or they continue to do those issues, and that joint seems to do okay for a while, but then puts too much emphasis on another joint that starts to have problems. And so it's sort of like whack-a-mole with these physical therapy appointments, with people, being in physical therapy more often than not, and you're not really seeing a whole lot of benefit.
Yeah, and I could see the frustration from that. And I've come across specialists in hypermobility. I know they're out there. Maybe we can, at the end of this discussion, we can kind of list some resources for people. But
Sure.
Do you, as far as the pain management world, what about when people are doing all their exercises and they're really, kind of working on things, being as diligent as possible, being as aware as possible. But, let's say they go on a long plane ride and just flare up. Like, are there other things people do for pain, like internal medicine stuff that I know there's obviously the NSAIDs, but I can imagine if, trying to cut down on those, or do you talk to people about other alternatives?
Yeah, absolutely. Sometimes we'll use a topical CBD oil, often with white willow bark added to it. White willow bark is the botanical that aspirin was derived from. So it has an anti-inflammatory property to it, but it also breaks down prostaglandin D2, which is released by the mast cell. So a lot of times our pain isn't always coming directly from the connective tissue piece. Sometimes it's also coming from the mast cell piece. So that becomes a really important piece. We also see a high prevalence of neuropathy in this population. In EDS, we get these weird, mildly autoimmune-like kinds of issues that sometimes will go into full-on autoimmunity to the nervous system. And so sometimes we do have that neuropathy-based pain, in which case, until we can figure out what's driving it and get that under control, a lot of times neurologists will use medications like Cymbalta or gabapentin or Lyrica to help with that. That sometimes helps to some extent. I personally find that, getting to the root of what's driving the problem tends to work better. If it does turn into a full-on autoimmune small fiber polyneuropathy, which occasionally it does, that's typically treated with neurological doses of IVIG, usually somewhere between 75 to 100 grams per month. That does exponentially help the pain and decrease the neuropathy after the nerves start to heal. So there are a lot of things that you can do. Certainly, I mentioned the proprioceptive insoles are some things that we sometimes use. Compression garments can be really helpful for pain. Sometimes they'll do oxygen therapy in this population. So it really depends on what's going on. And then long term, if the pain isn't alleviated by doing some of these things, we also do additional diagnostics, because sometimes we'll find craniocervical instability, or we'll find Chiari malformations, which is basically when the brainstem is actually going into the spinal cord itself. And so you need to make sure that they're not somebody who absolutely is going to need surgery, although not all of those diagnosed with those conditions will. Sometimes the work that Sabrina does is enough, and that is preferred if we can prevent surgery, because particularly with cervical cranial instability, they basically fuse the joint in the spine. And anybody who's ever gone through that knows you start fusing, and the doctors never stop fusing you, and because you continue to have more and more spinal dysfunction, because we're supposed to have mobility in our spine. So if we have one spot that becomes hypomobile and the rest is still very hypermobile, you're going to have continuing pain and problems.
Yeah. Well, it seems, there's 1 in 5,000 estimated people who deal with Ehlers Danlos syndrome. Is that still kind of the fair estimate? There's only 2 of you.
There's only has EDS, so it feels like 100 out of 100 in my practice, but
there's only 2 of you.
Probably an accurate number, maybe a little bit more prevalent because it's so underdiagnosed. One, there's a fear on the part of the person the geneticist, because there were multiple changes fairly in the last 5 years for the diagnostic criteria. The first made the criteria so strict that nobody was getting diagnosed, so they pulled it back so that people were getting diagnosed. But there are still a lot of people who are scared to make that diagnosis, and really only a handful of geneticists that I would say are connective tissue disease experts out there.
Yeah. I mean, we're lucky to have one out here in the Northwest, and I know to get into a geneticist is usually like a long wait. I've had people have to wait 6 months to a year, and luckily this is changing due to telemed. You can go be seen other places without having to wait. Speaking of that, are you able to do Pilates lessons on telemed, and are you conducting some instruction that way?
Most of the work that I do is via Zoom. It's online, FaceTime. Its platform is amazing because you can really see what people are doing. They can really see what I'm doing. And most of the time I feel like I'm right there in the room with them. In fact, I've had people say to me, well, how did you see me doing that? And I always tell them, don't worry, I'm seeing what you're doing. That's right.
Yeah.
But yes. So without question, we work with people all across the country, not just for Pilates, but with everything in Jessica's practice.
Yeah. A lot of my patients, I think several of my patients have gone through your practice, and it's just been very helpful. And I encourage, all my colleagues to really get to know what you guys are doing, because there's just a level of understanding that unless you've seen a lot of these conditions that you just don't get unless you've really you dive into it.
They don't all look alike, even though they may have some commonalities in their diagnoses. And I think that's the important thing. You might be able to suss out there's something off in terms of how many injuries they have, or this person's having GI issues and a lot of weird food reactions, or somebody might have dysautonomic kinds of symptoms. But putting it all together and figuring out what drives it, that's a niche, and it's something that I've really honed over at more than, I don't know, it's probably close to 15 years of experience working with this population. And even for myself, part of the reason I can do my job so effectively is it's not just the people within my direct practice, but my contacts and colleagues that work with this population. And, there are geneticists and neurologists and immunologists and orthopedic specialists and, all sorts of other kinds of practitioners that I interrefer with. And so, really important because I know metabolomics and I know genomics and I know a lot of the medical diagnoses, but at the end of the day, I can't do the physical exam and I can't make a prescription. And while I might master certain aspects of these things to be able to see it, I often need that input from another person because these are complex patients. And so the way I have my practice set up, which we're constantly, we all see the same patients, so we do these sort of grand rounds. I also do that with a number of physicians that are typically also on the team that are not directly within my practice.
Makes sense. Yeah. Well, let's talk about resources for people going forward, as far as if someone's sitting at home and they are convinced that this is what they're dealing with, or they've been given a diagnosis and they feel kind of lost on their own, trying to figure out like how to assemble a team. Besides, I want you to please tell us about your practice, and of course we'll share links, but if you could also talk about some organizations and other resources.
Absolutely. So one of the first places you should take a look at is the Ehlers Danlos Society, which has a great website with lots and lots of resources, education, physician directories. That's a really good starting place because, I certainly have various relationships with different physicians and all, but knowing who's maybe local to you would be really helpful. There's also links for things like support groups, which can be really helpful, and we all need that. There's a lot going into somebody that might have this kind of issue. They have all of the diagnostic criteria, so if you're not sure whether you meet the criteria or you want to just print it out and take it to your GP, maybe not for a direct diagnosis, but to say, hey, look, I stumbled across this. I think I might meet the criteria. Do you agree with me? And does this warrant a referral to a practitioner that really understands EDS? Because that's a good first step for you. I mean, you have to start someplace, and you can't necessarily even get in with that top specialist until you've actually gone through that process, depending on insurance. So that's really what I would recommend as a starting place. And then, after that, do you have symptoms that might be related to a mast cell disorder or dysautonomia or other kinds of things like neuropathies that we do see in this population?
Excellent. Yeah, those are really good resources. I also would just want to put a plug in for most local children's hospitals will have some compiled resource list as well. I know like our local children's hospital, Seattle Children's, has like EDS friendly physical therapists that they can also provide. But like you said, that can mean a lot of things, and it really does take someone who's spent a lot of time working with Ehlers Danlos to actually be a specialist or an expert. So, well, on that note, if you could just leave us with some take-home messages, and also just to share a little bit more about how people can work with both of you.
Absolutely. So I think the take home is, if this feels like a diagnosis that might ring true for you, don't ignore it. Especially if you're young. A lot of young people have symptoms and they feel like, I can kind of live with this. It's not going to go anywhere. And how you deal with it when you're, let's say, 20 something is not how your body's going to handle it when you're 40 or 50 something. And you haven't taken advantage of, the benefits of being young and stabilizing your body versus being a 50-year-old who is very deconditioned and in a lot of pain and now needing to work on it. So go after it. Know that you're going to need to self-advocate, because even at the GP level, you may find that there's like a brick wall that you hit, and it's okay to fire your doctor. Anybody who's ever had any zebra disorder knows that not everybody's going to believe everything they see or be supportive. If that means finding somebody that is willing to do that extra work with you, go ahead and do that. There are lots of us specialists out there. Who you work with has a lot to do with who you resonate with. Some patients are going to gravitate towards the person who's going to medicate and, do very traditional physical therapy, and there's a place for that. Then there are other people who say, look, I've already gone that route and it only got me, this much better. And you really want to kind of do some hard work yourself. That's the kind of person that's going to resonate with our practice, where we're really more comprehensive, and we're going to do a lot with your food, and we might do supplements, but we are going to do Pilates, and we might do neural retraining. We might send you off to work with some of the, the top immunologists or neurologists or whatever it is you need. It's going to be very, very comprehensive, but that means putting the time and effort into your health. And then the other thing that I think is really kind of important, because not everybody's going to be able to afford every piece that we have in our practice, is a project that Sabrina and I have been working on really through the entire pandemic. It's given us an opportunity to really concentrate on it. And that is, we have been putting together a series of Pilates-based corrective exercise videos for the Ehlers Danlos population. So that's really exciting. We're hoping that the level ones, their final stages of editing, we're hoping to launch that sometime in January 2021. But that's really something that anybody could get involved with without even doing anything else within the practice, kind of get a taste for what it might be to kind of stabilize their body. And I'll let Sabrina describe the videos a little bit more in depth.
Yes, so the videos are great. We have got 3 series. The first one is very basic movement. So the person can actually pick if they want to just work on their neck, or they just want to work on their foot, or maybe their knee is bothering them. So they can kind of go through a series of exercises just specifically based on Joe's work that would be beneficial just for whatever area of their body they're looking for. But then if they like the work and they want to progress, they can also, on their same level, and that's starting very basic level, they can actually take a few full classes that they can have in their repertoire. So even if they're actually doing Pilates as a regular, weekly or, bi-weekly, or, even some people come 3 times a week, depending on what their needs is, they can have this series of videos of actual classes that they can do when they're not actually in a Pilates session. But the other really big thing for people to remember with EDS is that movement is medicine in a way too. So a lot of times people think that, just staying still, or just kind of, I'll just hang out on my couch in this kind of slumped down position and I won't have anything happen to me. That's actually going to create more pain. So movement is medicine. And when they start learning to move, they start learning tools to use when they do have pain. So the movement can become actual medication. It's like a toolbox. So, okay, I'm on a long flight and my neck is hurting me. Let me make sure that I start moving, and every 20, 30 minutes, I'm not sitting in one position. Let me do this particular exercise where I'm, really kind of adjusting my own neck. Or I'm, kind of working on bringing my scapulars down. So they start learning tools that really help them with pain relief.
That's great. It sounds very empowering, which I think is like getting back to the mental health aspect, is like the more we're in the driver's seat, the better our mental health is. Like the feeling of not being in control is one of the worst variables in mental health. So, of course, the tools and learning and all the different techniques that you're teaching us puts the patient in the driver's seat more. And
Exactly.
I really like that. Well, thank you so much for this. It's been very educational to me, and I'm sure to other people. Again, could you just mention your website or the best place for people to contact you?
Sure. So the practice website is mastcelladvanceddiagnostics.com. Or if you just want to email us, it's info@mastcelladvanceddiagnostics.com, or you can reach us at our phone number, which is 860-321-7234.
Excellent. Well, thank you for being with us. We will be posting some links in the show notes and sharing this episode and playing it back for people who didn't get to see it live. And look forward to catching up with you further down the road.
Absolutely. Thanks for having us.
Thank you so much, Adam.
Yes.